Hi guys, this is the complete package of surgical anatomy of thyroid with surgical demonstration with handling of surgical complications. So this surgical anatomy of thyroid is very important. So I will discuss it with detail and with demonstration. Hi guys, I am Dr. Sunil Sharma. Now today's topic is surgical anatomy of thyroid. This is very important topic and it's most common surgery in the world. That's why today we are talking about surgical anatomy of the thyroid. Thyroid word coming from thyros. Thyros, it's Latin, means shield. It's shield like structure. That's why it's shield, just like this is shield. So this is called thyros, name thyroid. Okay. Now thyroid is reddish brown color. It's reddish brown color, butterfly shape. If we talk about dimensions, this is trachea. This is butterfly shaped thyroid gland. Okay. Now dimensions are, if we see length of this lobe, it's formed by the two lobe and one isthmus. This is isthmus. Two lobe, one isthmus. Total weight is about 25 gram. It higher in female than male. Weight is higher in female than male because of maybe during pregnancy or hormonal changes. Dimensions are, it's 5 cm in length, transversely it is 3 cm, and anteroposteriorly is 2 cm. So dimensions are 5 into 3 into 2 cm square. Length, transfer diameter and AP of the individual lobe. Isthmus, if we talk about this isthmus, it's about 1.25 centimeter into 1.25 centimeter. It is square in shape. Okay. So this is 1.25 into 1.25 centimeter. If we talk about surfaces, this is apex, superiorly apex is small, base is broad, this is base. This is anterior border, it's having two border, anterior border. This is posteriorly, from front to backward. This is posterior border. Two border, apex, base, anterior border, posterior border. Three surfaces. If we draw this, suppose this is the lobe. This side is medial surface toward trachea. Okay. This is anterior or lateral surface, medial surface, lateral, and posteriorly behind this level at this is posterolateral surface. So this is having apex, base to border, anterior border, posterior border, three surfaces: medial surface, lateral surface, and posterolateral surface. If you see isthmus having, this is superior border, this is inferior border, and two surfaces. One is anterior surface and posterior surface. Anterior and posterior surface. It's very simple. You have to understand. It's not. You have to remember it. It's very fundamental, and you have to understand this. Now, if we talk about blood supply. Before blood supply, I will tell you extensions. Anteriorly extend from mid-level of mid-level of thyroid cartilage inferiorly to the fifth tracheal ring. It's extend from mid-level of the thyroid cartilage, you may say oblique line of the thyroid cartilage, till fifth tracheal ring. At vertebral level, it extends from C5 to T1 vertebrae. It extends from C5 to T1 vertebrae. It means C5, C6, C7 and T1 vertebra. It's situated in the lower neck. Okay. Now we will talk about blood supply. Thyroid is supplied mainly by two arteries. Superior thyroid artery or inferior thyroid artery. Okay. So superior thyroid artery is coming from first branch of external carotid artery. Its first branch, superior thyroid artery is coming from first branch of external carotid artery. It's supplying from apex to the upper one third. It divided into anterior branch and posterior branches. And these branches, posterior branches, are anastomosed with the inferior thyroid artery. It's coming from external carotid, that is first branch of external carotid artery. And same, if inferior thyroid artery is coming from posteriorly, it's not coming from the base, it's coming from posteriorly. It divides into anterior and posterior branches, and these posterior branches supply the anastomosed with this superior thyroid artery. Here, one more artery is also its branch of thyrocervical trunk. Thyrocervical trunk. Okay. If you see this coming from thyrocervical trunk, if you see this is subclavian, this is common carotid, and this is brachiocephalic trunk. And this is first branch of, that is thyrocervical trunk. So this is coming from this is thyrocervical trunk. It is thyrocervical trunk is first branch of this subclavian artery. That's why it's coming from or you may say brachiocephalic trunk. That is coming from thyrocervical trunk. This inferior thyroid artery. One more artery is coming from here at the base, that is called thyroidea artery. It's found in 10% of cases. Okay, it's coming from brachiocephalic cephalic trunk or arch of aorta. It may come from brachiocephalic trunk or arch of aorta. So there are mainly two branches, superior thyroid artery and inferior thyroid artery. Okay, this is anterior and posterior. This is divided into again two branches, and these multiple, it may have multiple branches also. This branch supply the inferior thyroid artery, also supply the parathyroid gland. If you see posteriorly, parathyroids. Parathyroid mainly supplied by the inferior parathyroid and this is superior parathyroid. Superior parathyroid is developed from the fourth or inferior parathyroid developed from the third pharyngeal pouch. Okay, so these parathyroids are mainly supplied by the inferior thyroid artery, which is branch of thyrocervical trunk. Now if we come from venous drainage. Venous drainage. Venous drainage of thyroid is this is IJV posterolaterally to the thyroid. One branch coming with the superior thyroid artery, this is called superior thyroid vein. One branch straight away coming from the IJV also, that is called inferior thyroid vein. Middle thyroid vein. So this is middle thyroid vein. And inferior thyroid vein coming from brachiocephalic vein and it's coming here, making plexus. It's multiple plexus here. Same from left and right side, multiple plexus. That is thyroid plexus is inferior jugular, inferior thyroid vein. So superior thyroid vein, middle thyroid vein, inferior thyroid vein, mainly three veins. It's coming from brachiocephalic vein. Brachiocephalic vein. So superior and middle thyroid vein coming from IJV and inferior thyroid vein which making plexus is coming from brachiocephalic vein, mainly left side. Okay, these are the venous supply. Sometime in between the inferior jugular vein or middle thyroid vein, inferior thyroid vein and middle thyroid vein, one vein may coming from IJV, that is called fourth vein. It present in 10% of cases, called Cocker vein. Cocker vein. Sometimes Cocker vein is present, which is coming between the middle thyroid vein and inferior thyroid vein. It's coming from the internal jugular vein. This is about venous supply. Lymphatic drainage of thyroid, mainly pretracheal lymph nodes and paratracheal lymph nodes. Paratracheal lymph nodes. So mainly, ultimately they are drained on the third and fourth cervical nodes, that is pretracheal, paratracheal lymph nodes. This is about venous drainage and supply. And now we will talk about development. Development of thyroid gland. It starts developing from third week and complete its development on third month. It starts developing at third week and complete at third month. It's coming from thyroid enlarge, or you may say median thyroid diverticulum plus ultimobrachial body, also coming from neural crust cells. This ultimobrachial body coming from neural cells, they forming the parafollicular cells. Parafollicular cells. So parafollicular cell developing from ultimobrachial body, which is part developed from neural crest cells, and these parafollicles secrete the thyrocalcitonin, okay, which ultimately decrease the calcium level, okay. Now it increase the uptake of bone calcium. Now this thyroid enlace develop from foramen cecum at the tongue level, also called tuberculum impar, and it descends downwards. This thyroid is descend downwards and ultimately divided into two lobes and isthmus. Okay, so sometimes this part is remaining in 50% of cases, which suggestive of pyramidal lobe. So pyramidal lobe may present this remnant part of the developing thyroglossal tract is pyramidal lobe, and sometimes it may connect with the higher bone, and this is called levator thyroidea glandularis. Okay, this is levator thyroidea. It is fibrous band connecting between the isthmus of the thyroid to the higher bone, found in 10% of cases. Maximum things are 10%, and it may thyroidema artery, it may Cocker's vein, or it is levator thyroid gland. But 50% cases may have pyramidal lobe. It's connected with isthmus to the neck. This is all about development of the thyroid. Now, surgically important parts. Surgical important parts. I will tell you very simple and logical surgical point. If we see, we have to preserve the superior laryngeal nerve and inferior laryngeal nerve and thyroid mainly. Its main branch which supply the cricothyroid is external branch of superior laryngeal nerve. Okay, so we have to focus this and this recurrent laryngeal nerve. Okay, mainly. So triangle of concern, if we see for both, for external laryngeal nerve, I will tell you Jones triangle, that is very important. And second one is Cernia classification, to avoid the injury of external branch of superior laryngeal nerve classification. For this, I will tell you OH Bayes triangle, and very important for me, I have operated more than 200 thyroid surgery. I am using for recurrent this triangle, that is Lowry's triangle. That is very important. You have to focus these triangles. These are very surgically important. I recommend to identify each and every branch. Sometimes this external branch you could not identify in 10% of cases, but 90% of cases you may find with microscope. It's better, and you may find with the loops. Okay, so I am operating under microscope or I am wearing loop. So it's very easy to identify the external branch of superior laryngeal nerve, and I am very simple to identify this OH Bayes triangle or Lowry's triangle. I will tell you both triangles. This is trachea. This is the thyroid. If we talk about external branch of superior laryngeal nerve, So these are the vessels coming from upper pole, superior thyroid vessels, and here is cricoid. So this is cricothyroid muscles. Behind this you may find inferior thyroid, inferior constrictor muscles, and behind this is inferior constrictor muscles. The triangle, Jaw's triangle, also called sternothyrolaryngeal triangle. Jaw's triangle also called sternothyrolaryngeal triangle. Its lateral boundary is formed by this superior pole and vessels. Medially midline and superiorly like this. It's covering like this. So this is like the strap muscles, from the strap muscles. Superiorly strap muscle, medially midline, and laterally superior pole and lateral. So you may say laterally superior pole with vessels, medially midline, and superiorly strap muscle. Okay, strap muscle superiorly. So floor is formed by the cricothyroid muscles. This is Jaw's triangle. Similarly, one classification is so you may identify this external branch is coming from middle cervical ganglia of vagus nerve, with ultimately superior laryngeal forming two, internal branch and external branch. This is internal, going through the cricothyroid membrane into the larynx, and one is external, supplying the cricothyroid muscles. So this external branch of superior laryngeal nerve is present in this triangle. This is called Jaw's triangle. If you see by microscope or look, you will easily find out. I have done so many surgery, almost 90% cases I am able to identify superior branch of external laryngeal nerve. Yeah, you may external branch of superior laryngeal nerve. One classification is very important, that is called Cernia classification. For this external branch of laryngeal nerve is type 1 and type second A and second B. This is three type. If this external branch of superior laryngeal nerve is crossing above 1 centimeter of superior thyroid vessels, above 1 centimeter superior thyroid vessels, it present in 24% of cases. Okay, if it is crossing less than 1 centimeter near the pole, less than 1 centimeter, it present in 48%. So most common finding is it mainly external branch present within the 1 centimeter of level of superior pole, behind this superior thyroid vessels. And third one is if it is present below the pole, superior pole, below the vessels or superior thyroid vessels or pole, it may cross here sometime behind this pole. So this is present only 15 to 20% of cases. So most common is Cernia is within 1 centimeter is found. This is related to this recurrent laryngeal nerve is also, I will recommend two triangles. You can find it out. If you know the triangle, you will get it in any thyroid surgery. Any thyroid surgery. Recurrent laryngeal nerve, right side coming from the below the right subclavian artery, and on left sides lobes coming from the below the arch of aorta. Left side below the arch of aorta from vagus, and right side below the subclavian artery. So length is higher, so chances of injury of left recurrent is higher on left side during any apical carcinoma or any carcinoma of the left lung and metastatic lesion. So left laryngeal nerve injury is more common than the right. So this triangle here Weiss triangle, or you may say Riedel's triangle. Same, Riedel's triangle. If you see this is common carotid artery. Here posteriorly common carotid artery. Superiorly inferior thyroid artery is coming from brachiocephalic trunk. Inferior thyroid artery, and this anteriorly or medially you may find this recurrent laryngeal nerve. So one boundary of this triangle is formed by the recurrent laryngeal nerve, inferior thyroid artery, and laterally or posterolaterally this is common carotid artery. But better triangle is, I will tell you, this is Lowry's triangle, or you may say Low's triangle. Low's triangle. It is, if you see Low's triangle, it become content medially. If you see medially, I am following this triangle. Medially trachea or esophagus, laterally common carotid artery, and superiorly inferior thyroid artery. So in between, medially trachea, esophagus, laterally common carotid artery, superiorly inferior thyroid artery, you will get this recurrent laryngeal nerve tracheoesophageal groove right up here. So this triangle is better during your operating. I would recommend to explore both nerve, external branch of superior laryngeal nerve and recurrent laryngeal nerve, both sides, because if we are confident we have explored the nerve properly, we didn't cut any branch of this, ultimately this is going to help you, even though there will be neuropraxia. So you will be confident that I have saved both nerves. So there will be, even though neuropraxia, you will continue you have to wait only. Otherwise, if complications occur, it is difficult to find it out after surgery. So it's better to identify these nerves before the surgery. If one important point I will tell you, if posterior extension of this sometimes form a tubercle, posterolateral extension is sometimes avoided because of injury of nerve. It's very close to the recurrent laryngeal nerve near the Barry's ligament. So this is called tubercle of Zuckerkandl. Tubercle of Zuckerkandl, okay, or you may say gland of the Zuckerkandl, but it's better to say tubercle of Zuckerkandl. If we are operating the thyroid, mainly injuries are, most common nerve injured is external branch of superior laryngeal nerve. This most commonly, because we are ignoring this, that's why it's getting injured during thyroidectomy. Second common is recurrent laryngeal nerve injury. Okay, this injury lead to decrease in pitch. If some singer is singing in loud, in high pitch, it's unable to sing after injury of this. It's very less recognized after surgery because nobody is bothered about it. But we have to take this, we have to save this according to our according to thyroid surgery principles. Recurrent laryngeal nerve, if we injured, there definitely paralysis of vocal cord, which may lead to hoarseness of voice or stridor. Okay, if both sides injured, we have to go through tracheostomy also. Okay, so we have to take precautions very judiciously. We have to operate thyroid. Second injury is most common is parathyroid. Parathyroid gland injury, which ultimately lead to hypocalcemia, or which may lead to tetany. So pre-operatively, if we are doing total thyroidectomy, I recommend personally go for serum calcium level, PTH level, and vitamin B3 level. These are very important because in Indian population sometimes we have very less. If we are operating total thyroidectomy, I would recommend go through this. If we have already deficiency of any of this, we can replace this. Okay, so at least you do serum calcium level or vitamin D3 level prior to doing total thyroidectomy. And parathyroid injury is common. There is, if you see, this is posteriorly, I am drawing this posterior surface. Okay, these are parathyroid. It's mainly supply coming from inferior thyroid artery. Okay, inferior thyroid supplying both the superior parathyroid as well as inferior parathyroid glands. If we are ligating away, initially a lot of book talking about this. If we are ligating away this inferior thyroid artery from the pole to avoid the injury of recurrent laryngeal, this is not recommended at all, because we have to ligate individual branches which supplying the thyroid only. We have to avoid injury of these vessels, otherwise you will lead to permanent hypothyroidism, hypoparathyroidism. It's more dangerous than doing thyroidectomy. Okay, so there is no recommendation to ligate away from the pole to avoid the injury of recurrent laryngeal. You have to identify both this recurrent laryngeal as well as individual branches to cut it. Okay, otherwise you will lead to permanent hypothyroidism. And similarly, you have to ligate the superior pole close to the pole. So I recommend this. I am against pressing this because we have to ligate individual branches to safeguard this parathyroid supply. Okay, even though how crude you are, if you lead permanent hypoparathyroidism, how crude you are, even you lead to permanent hypothyroidism, I have three solutions. You may, if you identify during the thyroid surgery, you may auto transplant. If color is changing of parathyroid, you can auto transplant the parathyroid nearby that sternocleidomastoid muscle or any sternal muscle. You can make small pieces, about 20 pieces of this parathyroid, go for projection, and you can during surgery you can auto transplant this thyroid. Second one, if you have any cryopreserved parathyroid, you may transplant it. That is also called auto transplant, initially taken from same patient. So this is called cryoparathyroid transplant. Its result is about 80%. This is almost 100%. It's So we have to transplant in same 20 pieces here in brachioradialis muscle. Brachioradialis muscle in forearm. During surgery, you may transplant sternocleidomastoid muscles in pocket. And this, even though you are very cruel and not following any principle, you may have allo transplant. Allo transplant. So you may have parathyroid gland, somebody else from your family, you can transplant it in brachioradialis muscle. This is also effective 70% without any immunocompromise. Remember this. So how cruel you are, even though you can having this permanent hyperparathyroidism, we can do allo transplant. Success rate about 70% without any immunocompromisation, without any graft versus host reactions. You may say graft versus host reaction. So, during if ideal surgery, ideally thyroid surgery, I recommend proper diagnosis, planning, imaging, and most important to identify each and every structure, So I will say here recurrent laryngeal nerve and external branch of superior laryngeal. You have to identify. You don't have to afraid. Oh, I am searching this. This is recommended by Leahy. It was first scientist who recommend to identify this. Before that, all Joel, Coker, Bilroth are doing blind surgery without identifying this. So thank you so much. This is today's lecture. Hi guys, this topic about important triangles in thyroidectomy or thyroid surgery. The most important thing about thyroidectomy is the meticulous dissection needed for preservation of the two nerves, external branch of superior laryngeal nerve and recurrent laryngeal nerve with 4 parathyroid glands. So triangle important for thyroid surgery are, first is OH-V triangles, or you can say another name is Riedl's triangle, are same. This is for preservation of recurrent laryngeal nerve. So in this triangle you can see superiorly this is midline, superiorly this inferior thyroid artery is coming, and laterally you can see our base formed by the common carotid artery, and medially you can see recurrent laryngeal nerve. So in this triangle, this disadvantage, this one of the boundaries formed by the recurrent laryngeal nerve, which we have to identify. So this is very difficult triangle to find out. Second triangle I am talking about is Lowry's triangle. In this triangle, superiorly you can see inferior lobe of the thyroid, laterally common carotid artery, and medially trachea and esophagus. In Lowry's triangle, you can easily identify the recurrent laryngeal nerve. Third triangle is recurrent laryngeal nerve triangle or inverted triangle. It is formed by the medially trachea, laterally strap muscles, and superiorly inferior pole of the thyroid. In between you can find the recurrent laryngeal nerve. Fourth triangle is called Joel's triangle. This is for external branch of superior laryngeal nerve. It is also called sternothyroid laryngeal triangle. It is medially midline, superiorly attachment of strap muscle, laterally by the upper pole of the thyroid, and floor formed by the cricothyroid muscle. In between you can easily identify the external branch of superior laryngeal nerve. It's coming like this. Cricothyroid space of rib. This is a vascular space between the upper pole of thyroid and the cricothyroid muscle, important for preservation of external laryngeal nerve. Now sixth triangle is triangle of concern. This is for bleeding purpose. It is mainly branches of inferior thyroid artery that receive meticulous hemostasis. So these small branches sometimes lead to bleeding. This is formed by the apex formed by the Barrett's ligament, medially trachea and base sternum, and the laterally there is ITA. The Cernier classification is for preservation of superior, the preservation of external branch of superior laryngeal nerve. It's type 1 if it is superior thyroid artery in upper pole. The external branch lies above 1 centimeter. It is type 1. If it lies less than 1 centimeter, is type 2A, and if it is close to the superior thyroid artery and upper pole less than 1 centimeter, it is called type 2B. So this is all about Cernier classification and thyroidectomy surgery. Thank you so much.
Hi guys, this is about steps of thyroidectomy or thyroid surgery. First, you have to review and reconfirm the diagnosis about by imaging, CT scan, clinical examination, and pathological previous reports. Now you have to keep patient in semi-fowler position, or you can say hyperextension of neck position, or you have to double wrap the head and chest both, because you have to apply the superior inferior flap or stitch the superior inferior flaps so that your exposure will be better. After that, you have to put Kocher incision according to the exposure. If tumor is large, you have to make large incision about 2 fingers above the supraesternal notch. It should be adequate enough to expose or remove your thyroid swelling. According to me, it should be, if swelling is 15 centimeter, you have to